So we hope everybody's having a good day and are excited to learn with you. And Steph was going to share some stuff with us potentially, maybe, or maybe not. But as always, we'll invite if anybody would like to think about Kirtan's case with us out loud. It's the best way to get the most learning out of the hour. How's everyone doing? What's new? Great. We have somebody who volunteered in the chat, and I don't want to mispronounce your name. Would you mind introducing yourself?
Hi, my name is Zakaria.
Zakaria, where?
Zach for short.
Zach, okay. Nice to meet you, Zakaria. I'm Zavin. Steph.
Welcome. Glad to have you.
Thanks.
Where are you? What do you do?
I'm finally a medical student at the University of Cape Town in South Africa.
Very cool. Steph and I spent some time in South Africa, our senior year of residency, and have very fond memories there.
Oh, lovely. Where about?
We were in Pietermaritzburg in one of the public hospital there for about 4 weeks, not too long, but we went there to do an observership of sorts during our last year residency. And we really enjoyed it.
I'm actually considering doing internship at Gray's Hospital in Pietermaritzburg. I've heard good things about it, especially if you're interested in internal medicine. So
yeah, we would go to grand rounds every week at Gray's. It seemed like a great hospital.
Yeah.
Okay. Yeah, please, if anyone else would like to join Zach, that would be great. Steph, were you gonna share anything, or should we try to get underway?
I can share just a couple thoughts. I was able to join live on Monday for Reza and Robbie sharing a case, as well as their enjoyment of solving cases together, which we all know well. I'll just make a couple sort of two brief points. This was the case of an older gentleman kind of coming in with confusion, disorientation, tremors, in the setting of being on some lithium therapy chronically, who ended up having lithium toxicity. I think part of the beautiful discussion I'd like to highlight is first just the approach to altered mental status, which we know well from clinical problem solvers in the mismnemonic. Robbie actually just did a great thing and took a step back further and said, when you're faced with someone who's confused, one of your first decision points is, are they awake and alert or not? If they're not awake and alert, right, there's a very short list of things that you need to worry about, including vital signs abnormalities, severe hypoglycemia. And he just made a point that the patient who's confused but awake and alert is really the person in whom you do an extended sort of evaluation using the metabolic, infectious, structural, and toxin pathology. And it was just a good standpoint to say, before we even release that schema on our clinical problem solving, the patient's overall state of being awake and alert and able to talk, which this patient was, versus somewhere on the spectrum of sleepy to comatose, is an important sort of starting point. Because if someone is really sleepy and out of it, your list gets a lot shorter, or there's many more things to evaluate for urgently on that short list. At the end, Reza did some fantastic teaching on lithium toxicity, and the pearl that I really took away that he did some discussion about is sort of the acute versus chronic manifestations, and really making a teaching point that acute lithium toxicity really manifests most frequently with GI symptoms, and then perhaps neurologic symptoms, whereas in chronic toxicity, you actually see the neurologic symptoms earlier. So he made the teaching point of anyone with lithium use who comes in with GI distress, diarrhea, thinking about toxicity with that syndrome, not waiting or expecting for them to have neurologic manifestations is an important consideration, because they can be acutely intoxicated instead of chronically with high levels. So that was really just sort of the beginning and the end of the case. But as usual, they framed it. And those were two major take-home points that I took from hearing their discussion.
Cool. That's not, I don't necessarily think of GI symptoms as a prominent one, so that's a good takeaway. For me.
One of the most common and prominent when they're sort of acutely with elevated levels.
Thanks, Steph. All right, well, last call, but we can go ahead and have Kirtan get ready, and Andrea get ready to scribe, and we can get underway.
Sure. So, firstly, I wanted to thank Steph and Zaran for giving me this opportunity. And I can see, Andrea is here, Shema is here, all my dear friends are here. So it's going to be great. So I would start with the title of the case. So the title of the case is a cryptic coordination problem. And for our first aliquot, we have chief complaint of difficulty in ambulation. And I will stop there.
All right.
Zach, tell us what comes to mind, or how you think about this symptom.
Gosh, I was praying that it wasn't going to be a neuro case, because my neurophobia is still at all-time high. But
it has not yet been ended.
Not yet been ended, but always on a battle to slowly decrease it year by year. I think so. I don't know who the person is. I don't know what kind of medical diseases the patient has, and I don't know the time of onset. If you told me this patient had been having difficulty in ambulation for months, I may have a totally different way to look at it. Whereas if it was some sort of acute thing, acutely, I start to think immediately. My brain goes. I start thinking about brain pathologies. But I have to stop there and just wonder, could it be something else? Could it be some sort of joint problem? Could the patient have had a history of a fall or something like that, and he's just in pain? This could be a GI complaint, and the patient's just feeling so out of it, in so much pain that they can't really move. But if I am to go to neuro, then acutely I think of something like a stroke, infection, autoimmune disease, a little bit less likely, but it will all depend on the time of onset. So, yeah.
I love all those points you make, Zach. And, the first being, like, obviously the title is a bit of a hint that not only might this be neurologic, but specifically even having to do with sort of the integrating, coordinating part of neurology, rather than just sort of sensation or strength, for example. But I think as a starting point, absolutely, the chief complaint of like hard to walk or falling is not necessarily neurologic, and could be everything from musculoskeletal, right, like pain, to sort of systemic hemodynamic orthostasis hypotension, right, to sort of metabolic diffusely affecting the brain, right? It could be myopathic, causing weakness. You have to really tease out, and both on history as well as on a thorough exam, neurologic and extra neurologic, try to define the problem, sort of refine that problem representation a little bit more. And yeah, a lot of times you will quickly reframe this into orthostatic hypotension, right? If not sepsis, you will quickly reframe this into lower extremity weakness, right? Or ataxia. And then you've made a lot of diagnostic progress. And then within the neurology, again, I love that you're mentioning time course, always super, super important. You've mentioned some mechanisms of disease, right? Like what went wrong? A vascular problem, stroke, right? But of course, with neurology, as Aaron has taught us, as we've learned over and over, very helpful again is to start with where the problem is, localization, and then to think about the types of disease, categories of disease that can cause a problem at that location. I think that's a really good start. And that would be my sort of similar approach of sort of try to define a problem more closely. It sounds like this will be neurologic, and then try to localize that problem a little bit more, whether it's motor, sensory, ataxic. And then if this is sort of ataxic, for example, you can think about sort of the various pathways in the forebrain, in the cerebellum, in the spinal cord that participates in coordination, and then think about what could be going wrong there.
Sure. So do you want more data?
Please.
Stefan? Yeah, sure. So for second aliquot in HPI, we have a 12-year-old female who presented with the 6 years of gradually progressive gait difficulty, tremors, frequent falls, and difficulty in walking and standing. She was actually unable to hold the objects as well. She was normal till 6 years of age, and since then this disease has been progressing. The patient denied difficulty with speech or swallowing. There was no change in cognition as per the parents or from the patient herself. As for the past medical history, the patient was born from an uncomplicated pregnancy. There was full-term normal vaginal delivery. At the birth, the weight was 2.5 kg, and there was no evidence of jaundice, encephalopathy, or seizures when she was born. So there was no neonatal admission. And as for the medications, she is not on any medications. For family history, she has a 8-year-old brother who has no illness, and the patient was actually born to a non-consanguineous parents. So there was no family history of consanguinity, and there is also no family history of febrile seizures. And that's the end of aliquot 2.
Thanks, Kirtan. Zach, I'm gonna match your neurophobia and raise it to pediatrics phobia too. Now we're really in territory. But thanks in advance to everyone in the chat for raising. I saw Jorge already put in pediatrics, my nightmare. So I think many of us, but I think we can apply some of the same principles that we've thought of already to the case of this 12-year-old patient. Zach, let me have you share any thoughts you have first.
I think the first thing that jumped to me was that like a young person with the years of slowly progressively neurological symptoms, I started wondering if something happened at birth. But then Kirtan already said that she had a normal birth and she was fine up until 6 years of old, until 6 years of age. I do think some of the muscular dysplasias can slowly progress, and you can necessarily be asymptomatic as you grow up, and then around a certain point, the symptoms can start to develop. But my other thing was, I'd want to know, how was she at 6? Was there any sort of trigger? Did she have any sort of viral illness? Did she have any sort of exposure to any sort of toxin or anything like that? What sort of environment does she live in? And the fact that there's no family history is also interesting. I think some of these muscular dysplasias do run in the family, and it doesn't seem that there's any other history of that. With regards to her symptoms, the progressive gait difficulty, I think it's difficult to localize where exactly that could be. I honestly, I do wonder where to go from there. Without a physical exam, I don't think I could localize it much further.
Yeah, well done, Zach. I think you picked up on something that Kirtan did well, which is in all this additional history gave us, he shared some very good clinical reasoning about what information we need in order to play into our differential diagnosis. So extremely important to know, right, about the birth history of this child. We heard that there's no, that we know of genetic relationship between the parents. And so potentially the risk for particularly any kind of Mendelian conditions goes down more, all just incredibly important and useful information. I guess Zach, you've done a beautiful job continuing to think about what categories of pathology could be problematic here, including toxic and environmental exposures, as you mentioned, muscular disorders. We don't have our physical exam yet, but let me bounce a question back to you, Zach, that I've been thinking of. With these symptoms of the difficulty walking with tremor, falls, and then difficulty holding objects, have we gotten any closer to identifying central versus peripheral, sensory versus muscular? What do you think? Because this is something I'm thinking about. I'm not sure I have the answer, but want to pose that to the group first.
So sorry, you're asking me to answer, or is it first the group?
Any sense on like where the problem might be right now? You mentioned, for example, muscular dystrophy, right, which would be a primary muscular problem. Do we think there's any sensory involvement or cerebellar involvement? Can we tell yet without the exam?
I think the fact that she's got both symptoms in her lower limbs as well as her upper limbs already made me think of potentially the cervical cord and above. With regards to the sorry, I want to read the progressive grade difficulty. I did worry about some sort of sensory ataxia, but that wouldn't really fit in within the symptoms of having issues holding. I definitely think it's cervical cord or above, but beyond that, I don't think I can localize it more.
Yeah, I'll say I'm not sure either, just to be very honest. And with your thinking, I think you know, there's clearly evidence of potential, I mean, in general, right? And in muscular as well as perhaps sensory issues. It's hard to say right now. The one thing that stands out to me that I'm wondering about reconciling and helping to start localizing is the tremor itself. I'll actually go back and cite again Monday's case that I briefly reflected on the beginning. The patient had a tremor as part of the presentation of this lithium toxicity, but one of the basic categorizations Robbie shared with the group of tremor, at least in adults, but I think it'll apply here in kids, is that it really can, if it rests in adults, it could go with neurodegenerative conditions like Parkinson's disease. If it's happening with activity, it really could go with kind of cerebellar dysfunction. And to me, that remains a concerning area given what otherwise may be ataxic symptoms in this patient. And then it can happen with sympathomimetic states, right? Any sort of ingestions or toxins also. So I'm with you, Zach. I actually can't quite localize yet, but hearing that there's a tremor as well as this difficulty of gait imbalance makes me want to start to wonder about cerebellar dysfunction. But again, we'll have to do a very focused exam to sense more in that. Otherwise, I'm with you. I love the categories that you're working on. You're thinking of degenerative conditions, whether neuromuscular or muscular primary. You're worried about certainly congenital conditions given the age. And as you highlighted before, you're worried about kind of environment and toxic problems that are there as well. So we'll see what info we get. Anything you want to add thus far?
I have two questions that actually, I don't know if there's someone who knows. So let's click on the chat and see if there is, and anyone please speak up. But you know, in my experience, in my observations, sometimes just weakness itself can cause tremor. You know, when I think about like the rare times that I have lifted weights and and when it's a little bit too much, right? You kind of do this thing. So I think when you're at the sort of towards the limit of your strength and you're trying to perform an activity that tests that limit, I think that kind of a specific exertional tremor can be a sign of the weakness. So you know, of the actual limit of strength being reduced and thus manifesting during daily activities. And then my other question was, can tremor be a sign of basal ganglia involvement, or is it just cerebellar?
I think basal ganglia, right? Like with kind of Parkinsonisms and.
Good point. Of course.
Yeah.
Yes. Depending on the type of tremor. Yeah. Okay. That was kind of a silly question. Thank you. Okay. Yeah.
If I may add, the one thing I was thinking about is that with regard to the tremors, I would have wanted a little bit more information, like what exactly do you mean by tremor? When was it happening? How long does it last, and so on? Because I think last week I was learning about syncope and seizures and how they can also cause muscle twitching just before the episode or after the episode or something. So could this tremor be a sign of a seizure or something like that? And that would make me think of something else totally.
Great point. Can I ask one more question? The dystrophies that were mentioned, those are X-linked?
Yeah.
Becker's and Duchenne's?
Correct us if I'm wrong. I'm seeing nodding though from, yeah, Hans
And does that
others.
mean that girls never get it, or it's just rarer and milder?
Right, they would need it's 2x.
Both of them would have to be
Yeah.
missing, because it's usually a loss of function.
Yeah.
Thing.
I think
right?
so.
Okay, cool.
One more just question about the story, Kirtan, before we move on. It stands out to me that these symptoms have been evolving over 6 years, and this individual is presenting now. I don't know if you're going to tell us more about that, but the long duration in a child of these very scary symptoms. I'm curious if you can comment on that, if maybe there were access to care problems, or that they really got noticeable just in the last year with the tempo increasing. I'm curious to hear about the long time frame before presentation.
So you make an excellent point, and I agree with you that there were problems in each of those aspects. So there was problem with access to healthcare as well. And another thing was that patient actually had been to many hospitals, but they were unable to make any substantial progress. So once I give you the diagnostic data, you will come to know that there were many pieces of puzzle that were there, but somehow they were not able to figure it out. That's why the patient was struggling. And of course, since last 1 month, the things had gotten so worse that she was not able to go to school as well. So, that kind of prompted them to come to the biggest academic center, and that's why they came.
Thank you. We're ready for more.
Yeah, sure. And for the tremor part, yes. So actually the tremor was, more sort of the intention tremor. And so whenever she would do anything, tremor would come and then it would go away. And now for the physical examination part, the vitals were stable. For the general examination, the patient was well appearing. She was calm and cooperative. There was no evidence of dysmorphic features. Now for the neurological examination, the patient was awake and oriented to space, person, and time. The cranial nerve examination was normal. And there is one important point that I wanted to mention. Actually, my residents told me that in such cases, the ophthalmologic examination is very important, because many of the congenital disorders, be it lysosomal, be it glycogen-storage disorders, be it mucopolysaccharidosis or whatever, they tend to involve the corneas or lens or something like that. So we need to do a thorough examination. So that is one point I learned from residents. So in this case, the ophthalmologic examination was clear. The pupils were equal, reactive, and round and reactive to light. The normal fundus, the fundoscopy was also normal. As for the motor strength, so motor strength was normal, 5 out of 5 in all the muscle groups. The muscle bulk and tone was also normal. As for the reflexes, the knee and ankle reflexes were absent, and the plantars were upgoing. So Babinski sign was present. For the sensory examination, there was evidence of impaired vibration and proprioception in the lower extremities, but the upper extremities were fine. For the cerebellar examination, as you guys rightly pointed that, maybe there is ataxia, maybe there are tremors, so it could point to cerebellum. So cerebral examination did reveal the evidence of dysmetria, and even, gait ataxia was present. And meningeal signs were not present. As for the extremities and skin examination, there was no evidence of stigmata of any other neurocutaneous syndromes. So there were no eye-slip spots, no macules or papules, no area of hyperpigmentation or hypopigmentation. And that concludes our third aliquot.
Amazing, Kirtan. Zach, you got what you wanted. You got a great neuro examination that hopefully will help us. What do you think?
It's not yet all out, so I just wanted to read through it again. The hyperreflexive, if I remember, weighing the ankle, not the ankles, the knees, and then she had upgoing plantar responses bilaterally. So that automatically made me think of some sort of upper motor neuron lesion in the spinal cord, right? I wouldn't have expected something unilaterally on one side of the brain to cause bilateral hyperreflexia and plantar reflexes. The fact that she has dysmetria and I can't remember what other symptoms she had of her cerebellar, but if I remember correctly, dysmetria is a specific sign of cerebellar ataxia, and causes of sensory ataxia and etc. don't usually come with dysmetria. It seems to be in the brain, but it seems to be a relatively diffuse process as well. I think also with that time course of it being 6 years, I'm firmly on something sort of neurodegenerative right now. And the impaired vibration and proprioception made me think about the dorsal columns, if those are being affected. And yeah, don't know where to go after that.
Zach, I don't think you should be neurophobic. I think you should be neurophilic. I think both your knowledge of the tracks, the anatomy, the sort of syndromic kind of features presentations, as well as your clinical reasoning that applies both to neurology and beyond are outstanding. So kudos. Yeah, and I totally agree on sort of like the spots that are lighting up on our MRI of the history and physical, right? So what can be going on there? So have you all heard the term subacute combined degeneration? Subacute combined degeneration. So that is a term that's most commonly associated with B12 deficiency, right? But the other syndromes that can mimic it are copper deficiency, as well as Friedreich's ataxia. And the combined part of it, I think mostly refers to the corticospinal tracts in the spinal cord, which is like the motor, long tract, part of the upper motor neuron axon. And the dorsal columns, right, which are the ascending soft touch, vibration, proprioception, sensory modalities that go up in the dorsal spinal cord. But these metabolic / genetic syndrome, I think, can also involve another long tract, which I forget which of the, I think it's maybe the spinocerebellar or one of those other minor long tracts that basically participate in coordination, and lesions of which will present with ataxia. And I think these syndromes can also involve those tracts. So that's the pattern that I'm seeing, that I'm a little bit on shaky ground. I think I would have to do a lot of practice-based learning, point of care learning, taking care of a patient like this to look up and make sure I'm not misremembering something, as well as I'm always just humbled, especially within neurology, how many syndromes and different illnesses are that I've never heard of, either because, again, during training, it was too much to cover and we didn't cover them, right? Or because they've been newly described since I wasn't training, or since the last time that I did have to read or take care of a patient like this. But that would be kind of my problem representation, sort of building on your localization of, yes, it seems to be potentially, dorsal columns involved. And yes, there seems to be an upper motor neuron lesion. More, it seems, of, let's see, of the lower extremities. Oh, okay, hold on. Something's not fitting here. There's absent reflexes, but upgoing plantars. Is that right? Absent reflexes, Kirtan?
Yes, that's true. And you are right. Actually, it's an atypical pattern, but it fits in our case, actually.
Okay, interesting. Sorry.
I think I'd heard hyperreflexia in the knees for some reason.
Okay. Yeah. So never mind. It's not as simple as what I kind of narrowed it to. On the other hand, some of these syndromes, certainly B12 deficiency, for example, can involve the peripheral nerves too. So you can have a concurrent kind of spinal cord process as well as a peripheral neuropathy, and the balance of what reflexes do could probably land anywhere in between. This is a bit unusual. I'm also, if the corticospinal tract isn't clearly involved, then kind of expanding more on a dorsal columns alone process, that would include syphilis, right? Tabes dorsalis. And that may be why maybe we were hearing a very detailed skin examination as well, in addition to some of the genetic syndromes that can be, involve the skin, various proliferative, right, lesions, along with neurodegeneration. But then the positive Babinski would have to be explained, you know, a different way. I've kind of gone in circles and stalled a little bit, haven't I? What's something we could anchor to? Steph, Zach, what's the anchor here? What would be best to kind of like refocus the differential around? What is most specific, or what do we know with the highest degree of certainty?
Yeah.
By the way,
I want to
earlier
say
on,
that,
go ahead.
that the sensory symptoms have to be explained, the loss of the vibration and proprioception. But that pattern of the reflexes not really fitting. The one thing I thought about is that I remember reading ALS can cause an upper motor neuron lesion on one side and a lower motor neuron lesion on the other side, but it's completely not the right pattern for that. Although she does have some of the similar symptoms in that her mental state is fine. She isn't having urinary issues or bowel incontinence, I think. But I just think, I don't think ALS ever presents in a 12-year-old, unless I'm mistaken.
I agree. And this prominence of sensory and sort of cerebellar symptoms too would be unusual, right? It should be entirely, or mostly, if not entirely, a motor syndrome. Though something tells me like some sensory symptoms can sometimes be present, but
yeah, I think the ataxia cerebellar, right? I mean, you made great points, Zach, about the kind of dysmetria really anchoring, even though we also have sensory issues. So, I mean, to me, I think sort of expanding the cerebellar dysfunction and where that can happen is probably might be the most fruitful sort of direction to go in as one problem. But then we do, as you said, have this other problem of the sensory deficits.
Yeah, I feel like this is what makes me most nervous is that, like, both for this girl as well as for the diagnostic process, is that there's some syndrome called some spinocerebellar degeneration or other that I'm just not familiar with. But can I raise a couple of questions and see what we think? Wilson's disease crossed my mind early on, just because of the, you know, kind of the sort of genetic metabolic vibes, kind of because of the chronic time course in a young person, usually mostly basal ganglia things. And if we were to trust the eye exam, you know, in the absence of Kaiser-Fleischer rings, doesn't seem like a good fit here, right?
Yeah, agree.
Zach?
Yeah, also I would have thought maybe she'd have diabetes or liver issues as well, something else that may point to it. Family history, I would have definitely expected. So.
Sure. And then there's no psychiatric sort of components for the neuropsychiatric part, though, because I do think especially younger people can present with only neuropsychiatric symptoms, but again, doesn't seem like a great fit. And then the other one was, could this be some kind of heavy metal toxicity? You know, usually there's, you know, with lead, for example, there's peripheral neuropathy, right? Which this doesn't seem like a good fit with, but I think there can be CNS effects certainly too.
Yeah.
So I think both, you know, doing sort of a screen for potential exposures on history, as well as looking for other supporting signs. And this might be a good segue into the next aliquot of kind of laboratory abnormalities, right? Whether that's in the CBC, in the electrolytes and renal function, it could be sort of a extra information helping for that line.
That's classic adult internist in a pediatric neurology case, just hoping the labs give us a signal. That's your cue, Kirtan.
Sure, yes. And you guys already making the great progress, and I think this aliquot would help a lot. And I just wanted to emphasize one point, that actually in the history I mentioned that the cognition was intact, but in the physical examination I forgot to mention that. So that's a key component, because like many of the disorders who tends to involve all this motor movement will also involve the cortex. and cause the cognition problem. But in our case, we do not have cognitive issues. I mean, she was going to school well, she was performing well. She just was not able to go to school because of the ambulation problem since last 1 month. And now for the last aliquot, we have the CBC, BMP, LFT, PT, INR, APTT, all were within the normal range. The HbA1c was 5.9%, so which is in the pre-diabetic range. The random blood glucose and the fasting blood glucose level were within the normal range. The patient had normal hearing threshold and brainstem conduction was normal. The EMG NCS, which, as Zevan was pointing to, revealed the absence of sensory nerve action potentials, which is conclusive for large fiber sensory type axonal neuropathy. And finally, for MRI, the brain MRI was completely normal, whereas in the spinal cord MRI, you find the diffuse thinning of the cervico-dorsal cord in the form of reduced anteroposterior diameter. So that is all we get in MRI, the thinning of the cervico-dorsal part of the spinal cord. And that's the final piece of data that I have. And the next aliquot, I will reveal the diagnosis.
Yeah, okay. Okay. I'm sorry. Okay. I was expecting a completely normal blood work. I would have been interested to know her B12 levels, but I wasn't expecting anything to be really abnormal. The HbA1c, not sure what to make of that. 5.9, it is in that range that I do wonder, but what the normal other tests, I don't think it's something to like anchor on, that it's some sort of disease like Wilson's or something that could affect extra neurological organs. With regards to the MRI, I'm surprised that there weren't any findings in the cerebellum. I thought this meteor was a pretty specific sign for cerebellar dysfunction. So I think that's interesting. And then diffuse thinning of the cervical dorsal cords. So now it seems to be firmly in the spinal cord and some sort of neurodegenerative disorder that doesn't affect the brain, which is interesting. I have no illness script for that at all. Not sure where to go from there.
I'm with you, Zach. I just want to make, so what we've got so far is, Kirtan, you said there a large fiber sensory neuropathy was confirmed.
Yes, and it was of axonal type.
So an axonal neuropathy, and then the cervical dorsal lesion is where we've localized. And I'll just say kudos, Zach, from the very beginning, based on the symptoms, and then later the exam, you were worried about cervical spinal cord, right? As a potential place to unify some of these symptoms together. So kudos on that. I'm not sure where to go from here. I think you are correct, Zach, to have some hesitation to make too much of the abnormal A1C. But I do wonder if that's going to be partially explained with whatever this diagnosis is. And it makes me wonder again about the sort of metabolic category in particular. I don't have much else.
Yeah, me neither. I think, I mean, there's some things that like we're definitely missing, right? Like we do need a B12. Like what if the A1C is signal? And well, I mean, type 1 like autoimmune diabetes doesn't present with an A1C of 5.9, right? Like it usually, whatever.
It's interesting you bring that up, because I was just reading that like autoimmune type 1 diabetes is heavily associated with celiac disease, which can certainly cause vitamin B12 deficiency. And then you write that she doesn't fit the pattern of a typical type 1 diabetic at all.
Yeah. And diffuse thinning of the cervical dorsal cord. Can we clarify, Kirtan, was this narrowing of the canal and thus, thinning, or was like the canal is fine, the bony parts are fine, but there's like atrophy of the dorsal columns there?
Yes, exactly. The later part. So basically the whole spinal cord parenchyma itself is kind of atrophied, and we do not have any evidence of hyperintensity or hypointensity or any fluid signal which can point us to inflammation or demyelination.
No, yeah, like more of a degenerative rather than inflammatory.
Yeah, exactly.
Yeah, I mean, honestly, a lot of Googling and neurologic consultation for me. You know, there's a reason why Kirtan is presenting this to us internists, I suspect, and we'll find out soon enough. But I feel like we're so close.
Can I just add that actually Zeven has alluded to diagnosis in previous aliquots? Can I just say that? I mean, you actually mentioned that term, like just the perfect syndrome, you know, you mentioned that term.
Yeah, I mean, we could guess. Yeah.
He named the diagnosis or the kind of syndrome?
No, he actually named the diagnosis, the right thing, you know, the exact term, not just some, you know, beating around the bush, just the exact term.
I mean, I think so. I mean, I think I forget if Friedrich's can cause any sort of peripheral syndromes, and
Sure.
Maybe it can.
That's it.
And actually, but I wanted to ask about that. You know, Friedrich's ataxia is a triplet repeat disease, isn't it?
Sure.
So usually for someone to present at 6 years of age symptomatically, and that the triplet repeat disorders exhibit what's called what's it called, anticipation, like where each generation it's like sooner, earlier and earlier, but there's no family history of anything like this in the parents.
Yes,
there is.
No, there is
no.
no.
There is
Wasn't.
no family.
Okay.
Which is seen with those conditions, right? That it's eccentric. I'm doing this. I'm adding more triplet repeats with my hands with every generation.
That's right. Okay, I think Kirtan just needs to end our suffering, and maybe after this I'll do a pediatric neurology residency or not. But take us home and teach us, Kirtan.
Yeah, so no, you don't need any residency, you already got the diagnosis. So you are exactly right that what can be the differentials. So where are the localizations? So we are localizing it to cerebellum, dorsal column, corticospinal tract, large peripheral nerve fibers, and even the ganglion part. So, you know, the way you mentioned that how we can get normal reflexes or even absent reflexes is very important, because you can imagine that the afferent part of the reflex arc is made by the large peripheral sensory nerve fibers and the dorsal ganglion. So if there is any pathology affecting either the dorsal ganglion or large peripheral nerve fibers, then we can expect that despite having the corticospinal tract lesion, you would get absent reflexes and not hyperreflexia. So that is, you know, classic the B12 picture. Like in B12 picture also we get areflexia along with hyperreflexia in some joints, right? So now what can hit those peripheral nerves? So we of course did the vitamin B12 levels, we did the copper, we even did the vitamin B1 levels, and all of them were within the normal range. Then what else? Then what can affect the ganglions? So as Zeven rightly mentioned, that tabes dorsalis, this is syphilis, can cause it. Vitamin B12 deficiency can also cause it. And even Friedreich's ataxia can cause it. And what are other differences that we can think of? So all the spinocerebellar ataxias, you know, like 1 to 13, the list keeps on growing, the new genetic alterations we found. But in those cases, you would expect at least some degree of cerebellar degeneration on MRI. It is not always definite, but we would expect that in such a drastic condition, it would be present. So that was not present in our case. And again, the cognition part. So there are various disorders which are characterized by NBIA, which stands for neurodegeneration with brain iron accumulation. So just like in Wilson's, the copper accumulates, there are other disorders like aceruloplasminemia, neuroferritinopathy, pantothenate kinase-associated neurodegeneration, A-beta lipoproteinemia, you know, the neuroacanthocytosis kind of thing. But in those conditions, you would expect cognition to be lost. In our case, cognition was intact. So it was pointing us away from that. And now the last part, that how to reconcile the HbA1c part. So, you know, I remember that few months ago, in one of the RLR Patreon sessions, we had a schema of hyperglycemia. And in that schema, there were, you know, various points like type 1, type 2, genetic. So in the genetic portion, what are some of the common diseases that we should think of? So Klinefelters were mentioned. Down and Turner syndrome can also cause it. Then mitochondrial disorders can also hit the pancreas. And then finally, myotonic dystrophy and Friedreich's ataxia. So Friedreich's ataxia can cause diabetes as well. And that's one of the reasons why we got the HbA1c in the first place, because nobody had got HbA1c, but we thought that maybe it would be prudent to get HbA1c so that we can make further progress. So that's why we got the HbA1c. And finally, even in Friedreich's ataxia, just like in myotonic dystrophy and other mitochondrial disorders, you can get cardiac hypertrophy. So it's essential to get the MRI the echocardiogram of heart, because the most common cause of death in such patients is often the arrhythmias, not just these neurological difficulties, but the arrhythmias. So we did get the echo, and the echo was fortunately fine. The patient had no evidence of reduced ejection fraction or no evidence of wall thickness, but that was essential point. And finally, to conclude, we did the genetic testing. So as you guys were mentioning, that GAA repeats were more than 66, and actually 66 to 1700 mutated alleles suggest that this is mutation and not the pre-mutation. So we confirmed the diagnosis of Friedreich's ataxia. And you are right, we were also surprised that why the family members are not involved. But the thing about Friedreich's ataxia is that it is one of those trinucleotide repeat disorders which can present very early on in the age. And maybe it is possible that the mom and dad were, just in the pre-mutation stage. And unlike in other trinucleotide repeat disorders, in Friedreich's ataxia, in pre-mutation disorders, usually the symptoms are so mild or they never appear. For instance, in Fragile X syndrome, often if we have pre-mutation, then you get what is known as Fragile X tremor ataxia syndrome. And this is important for our case because when females have Fragile X tremor ataxia syndrome, we have tremor, we have ataxia. So it kind of fits with that. But such females are unable to produce the eggs because they have ovarian insufficiency, and that's why they suffer from recurrent pregnancy loss. So we are worried about that what if this patient has Fragile X syndrome, and maybe in future there could be issue with conception and everything. But it was not Fragile X. It was finally confirmed that it was Friedreich's ataxia. So that was our differential. And I think the point which Zevan made kind of sealed the diagnosis, that large peripheral nerve fibers could explain these reflexes and everything. And he mentioned Friedreich's, just out of blue in between. So he knows everything. So it was great.
You're a pediatric neurologist after all.
Yeah, I don't need to do the residency. Kirtan, this was amazing. Thank you for the teaching, the very challenging, humbling case. Thank you. And Zach, really pleasure to meet you. Awesome discussion today. Thanks everyone else, Andrea, Semya, for scribing and for the teaching points. So Senya, were you gonna summarize a little bit and conclude for us?
Sure. So, Kirtan, awesome case and very great discussion. So, summing up the case, we had a very young patient with difficulty in ambulation, and our first thought was that time is course. We know if it's an acute problem, it could be neurological, a vascular, musculoskeletal problem, a myopathy or metabolic issue, or even orthostatic hypotension or any infection. And also it is important, if we go to the neurological schema, the localization is important. Is it in the cortex, in the brainstem, spinal cord, cerebellum, like it is atactic? And we saw that this patient had progressive gait difficulty. So we are thinking, is this any hereditary or acquired thing? Like if it's hereditary, thinking of any muscular dystrophy, SMA, dystonia, myotonia, or if you think of acquired things like heavy metal intoxication, lithium intoxication, what we learned before, or is it any brain tumor like medulloblastoma, pilocytic astrocytoma, which are common in young people, and which he also had tremor, and trying to think of what can cause tremor. We know weakness can also cause it, next to things like Parkinson's, cerebral disorders, or any metabolic issue leading to enhanced physiological tremor. And putting the framework together, she had cerebral signs, and also we saw both upper and lower motor neuron involvement, like she had a positive Babinski sign, and also gait ataxia and impaired epicritic sensation, which let us think about any cerebellar or spinal cord affection, like whether the dorsal cords are affected, or is it the cerebellum? Like for dorsal cord degeneration, we think of metabolic things like B12 deficiency, copper, and thinking of hereditary things like Friedreich's ataxia. And coming to the case, the person had diabetes mellitus type 1, and there are several diseases that are also linked to diabetes mellitus type 1, like celiac disease, autoimmune polyglandular syndromes, stiff person syndrome, myotonia, and in this case also Friedreich's ataxia. And yeah, thank you very much.
Fantastic job, Samia. Really great encapsulation of all the teaching points. Thanks again to Kirtan. Zach, congratulations. It was really, I feel lucky that we got to go on this case solving with you. And it was great to see everyone. Have a great rest of your Wednesday, however many hours are left in it.
Bye.
Bye. Take care.